At the risk of the obvious, how's everybody doing? Awesome, right? I'll tell you, there's nothing better than doing a period of instruction for 2 hours after a test, right? Because the bandwidth, I don't know what it's at, but it may not be the highest. But today we're going to finish up the lectures for this block, okay? And then we're going to look, set our eyes on the horizon for our lab on Wednesday, correct? Okay, lab on Wednesday. We're going to meet up here first. Everybody will be in the appropriate PT here. I actually do a switch day. You got switch services. All right, have some fun with it. Yeah. I don't know, Chrome Sylvester coming in for that. But we're going to meet up here. We're going to watch the videos, which are free for you guys to peruse right now at your leisure, or leisure, fancy. And then we're going to transition to downstairs. I've put here plenty of instructors, right, so that they'll be able to facilitate you guys practicing. But we will do a demo, okay? I'll break up the class, half with me, half with Colonel Sylvester, the other with the surgery PA, and we'll do demos. That way you guys don't do the wrong exam for 2 hours. Okay, good to go? Nobody laughed that time. All right, but seriously though, because that's something that I'm looking to improve, making sure you guys understand, like, how are you supposed to be doing this test? What is this supposed to feel like? What are you supposed to tell your patient as you're doing the test? And what is a true positive versus a true negative for a test, right? Can a special test be mildly positive? Yes. Okay, it can be suggestive, correct? And you're gonna document stuff like that. But we'll get into that a little bit more. Just understand, when it comes to the spine exams, it literally is spine, right? Because we always talk about spine in relation to shoulder pain, spine in relation to hip pain. We're only going to focus on the spine for now, okay? So, again, at the risk of drawing ire from the group, we were all able to put some time into our activity, excuse me, not plural, activity this weekend. If not, you have until 11:59 hours to submit it this evening, okay? That's what, 4 extra days? Oh my God, Ortho has homework. Okay, I gave you 4.5 extra days, or whatever the math comes out to. Okay, if you're still struggling, let me know. Okay. All right, we're going to finish up with lower back pain. So this is lower back pain acute, right? This is pain that somebody presents with on physical exam. On history, they're going to tell you what? They're going to tell you that they had some story where they had poor lifting technique, they're out of shape, right? Something like that. There's going to be a precipitating event. So make sure you get a good history with this, okay? But just understand this is lower back pain acute, not lower back pain when it relates to lumbar spine radiculopathy or lumbar spine stenosis. We good with that? Okay. So again, there's your definition: strain, paravertebral muscle injury. Okay. So if you feel it's muscular in nature, then you're going to call it a strain, correct? The word strain, yes. Okay. Exciting. All right. So strain has a T in it. Does muscle have a T in it? No. Okay. Notice I didn't use the word tendon, right? Because tendon does have a T in it, so that breaks my rule. But just understand, muscles are strains, therefore tendons too, right? And then what is another one on there? It's sprain, right? So sprain is ligaments, correct? So do you think, again, lower back pain that you're going to be able, lower back pain acute, that you're going to be able to discern which is which? Not necessarily, right? But we do understand that when it comes to intervertebral pathology, that when we're talking about the discs, that may be different. Then we start talking about radiculopathy versus myelopathy. Okay? What's in yellow there? 80% of patients with lower back pain will have no specific diagnosis. Good to go? No specific diagnosis. And of course, I left my clicker at home. But most of the times they're going to have acute onset following your lifting activity, some kind of, high impact activity. we'll sum it up with that, right? So when I was a chief medical officer for School Infantry West, I didn't even have to ask them. They just came back from an 18-mile ruck. Okay, what were you doing? I don't know. I was just trying to survive, sir. Okay? But they'll have some kind of precipitating event. Good to go? Okay? Leaning over to pick up a piece of paper, leaning over to pick up a box. That picture is supposed to kind of show you, give you an idea of that. Okay? They can have lower back pain that radiates to the buttocks and posterior thighs, but it stops above the knees. Okay, again, this is acute lower back pain, not radiculopathy. Okay? Difficulty standing erect? Sure. If they have spasms, is it going to hurt to try to stand up straight? Yes. Okay? And they may need constant position changes. Okay? Physical exam, they're going to have literally point tenderness in the lower back region and also the SI joint region sometimes, right? So can you have lower back pain that's paravertebral and also involves the SI joints? You can. Okay? But here's the key. What's in yellow there? Neuro exam is normal. Okay? So when you guys are doing your testing, pants or otherwise, make sure you key in on the neuro component of it. Neuro does include motor, sensation, and also reflexes, correct? So don't miss those aspects of it. Okay, there'll be some kind of an indicator. So imaging-wise, what are you going to get? As astute clinicians, you're always going to get radiographs, correct? AP and lateral at a minimum, okay? But are you going to get them right away? Defer for 4 to 6 weeks. This breaks my rule. Why? Because there is a HEDIS metric. Does anybody know what HEDIS is? Somebody in here should, right? I don't remember what the acronym stands for, but basically it's like a protocol, right, that we follow. It's a metric that we measure in the military and in civilian practice as well. And it basically states that if there's no actual trauma, right, it's just a muscle strain or sprain, then you can defer radiographs for 4 to 6 weeks. Okay? We good with that? All right? So you have a precipitating event, no major high energy injury, they don't have any neuro symptoms, right? You don't have to get x-rays right away. You can wait 4 to 6 weeks. If they have trauma, if they have neuro symptoms, are you going to get x-rays? Yes. Okay, that's the difference. Okay, it still kind of follows the rule. Right, so they can have pain at night. Obviously, if it's position changes and things like that, they're sleeping in a poor position, they get pain at night. Okay. But what are we talking about here? We're talking about pain that wakes them up at night. Okay, so if they have atypical pain, that's what that slide is saying right there on the right-hand side. Atypical pain, meaning, what are the things we worry about? We worry about sudden loss of weight, fevers, night sweats, right? Back pain, wakes them up at night. You're thinking of the C word, correct? Chlamydia? Ooh. You guys already had that test. All right, it might be chlamydia. But you're trying to rule out the cancer, okay? Now you guys are all over it, huh? You want ID test 1, part 2? No? Okay. Got to know. Right? So just understand that if they have atypical symptoms, right? So they had a lifting injury, and now they have neurologic symptoms, you're going down a different path. That's an example there, okay? Good? Beat the horse is dead. Okay, so otherwise, conservative care, I'm going to let you read to that there. If you're going to give them quarters or whatever, short period. Motion is lotion, okay? A day or two, right? That's it. Get them moving, right? What's the enemy of orthopedics? Stiffness. We're combating that enemy at all times. Return to full duty is the goal. You can return them to full duty and give them a PT referral. Make sense? You don't have to say, well, you're on light duty or limited duty or whatever service you're in, right? Limited limdu in the Navy, right? You're not on limited duty. You're not on a profile, right, necessarily. You can return to full duty. You just tell them, I'm going to put a consultant for physical therapy. Good to go? So key in on this, what's in yellow here. Exercise and what? Remaining fit equals lower recurrence rate. Well, that's kind of intuitive, right? So if you're fit, you're gonna have less injuries, right? So if you perform regular exercise, you have less recurrence, okay? So do you think that that's gonna be part of your plan, if you're doing a plan for like an off-ski or something like that? It is. Reassurance, education, correct? That's the education portion of it. Telling them, you're gonna need you to exercise 2 to 3 times a week, minimum. Cardio, 30 to 40 minutes every day, correct? Not once a week, it's not twice a week, or the 3 mile a year club in some services, right? So they run a mile and a half, 2 times a year or whatever, okay? It's maintaining that level of fitness. Is that course dead yet? Yes, it is. Okay, good. So these are the topics that we covered between last lecture period and today. So that kind of brings that lecture to a close. I'm going to open it up right now just to say, hey, is there any questions about these? Because I think it's important for you guys to understand. We did talk about radiculopathy versus myelopathy. So understand radiculopathy follows a certain distribution, correct? Myelopathy can be more confounding because it involves the spinal cord, correct? Okay. So Codd-Equina syndrome, you must know that. You will have to know that for the rest of your career. Okay? Codd-Equina, is that a surgical emergency?
Yes.
100%. Okay? So you will see that again. And you will probably see that on pants in some way, shape, or form. Okay? Cervical radiculopathy I just discussed, but just understand cervical radiculopathy, is that a surgical emergency? No. Okay? Unless, right? But for the most part, you're going to deal with that, especially with half bears, people that wear helmets, people that jump out of helicopters, stuff like that in the military. You're going to deal with that. So not all of them need a referral right away. So understand those treatment goals, right? And understand that surgery is reserved for certain subsets of patients, right? Okay, so as you're studying, look at that. Cervical strain is not cervical radiculopathy, correct? Is not. Are there any neurologic symptoms of that? No, not necessarily, right? They can have what they call non-focal pain. We talked about that, right? Meaning it's kind of like here, right? This morning when I woke up, it all hurt right about here, right? And then I got moving, and my osteoarthritis, got better. Okay, discitis, know it. Discitis is infection. Is that a surgical emergency? Know it. Now understand the difference between discitis, less than 5 years old, and then what's the one that's above 5 years old? Vertebral osteomyelitis is what I heard. That's the correct answer. Okay? Kyphosis, all right, understand that that's that forward curvature in the lateral plane, or sagittal plane, if you will. Okay? Today we're going to talk about scoliosis. Understand the differences in those degrees based on which plane you're in, okay, guys? I'm forecasting the next discussion about scoliosis. Okay? Don't get those sets of numbers confused between the two conditions. Can they coexist? Yes. Right? But just understand the differences. Okay? Understand which plane you're in. And we just talked about lower back pain acute. No questions? Questions? Question mark? No? Okay. All right, moving on. Spine pathology. We're going to discuss lumbar herniated discs, right? Lumbar spinal stenosis, metastatic disease, okay? Scoliosis, spinal listhesis degenerative, spinal listhesis ismic. Okay, why is it written that way? Because that's the way the PANCE blueprint is written. So you guys can correlate that, okay? That's just for continuity's sake. For consistency, I should say, okay? So starting with lumbar herniated discs, again, we talked about the donut with the jelly in the middle, right? Right, so it's important for you to understand that that concept still applies here. So the nucleus pulposus, is that the jelly? It is the jelly, right? It's being expressed. Right, it's herniating. That's why it's called a herniated disc. Okay, and it's irritating the nerve root. Can it cause radicular symptoms? Absolutely. Okay, so those radicular symptoms, they can be pain, numbness, and or weakness. Okay, remember we discussed the difference between paresthesias and true numbness. Understand that that's a spectrum, correct? Okay, so understand the difference. Okay, it can be in one or both lower extremities. Okay, it can vary based on position. It can vary based on activity, correct? All right. Most commonly occurs at what level? Right, L4, 5, and then that's the L5 nerve root, correct? Okay, and then that's followed by L5S1, which is the S1 nerve root, right? Okay, so we're getting back to our anatomy again. These pictures here again are a review. It's really not much different than the cervical thing we talked about, but just understand these are different levels. So when you're studying, understand where they occur. Okay. If you're talking about cervical, what level does it commonly occur? If you're talking about lumbar, at what level does it commonly occur? Okay? So this is a picture that's supposed to denote the distributions, okay? It could be, again, remember it's one or both sides, right? So this distribution can vary. All right, so it's important to understand that if you have this kind of pain, it can vary depending on the distribution, right? So do you think your physical exam is important? 100%. Okay. Clinical symptoms-wise, they're going to come in. They're going to say they have severe pain with minor activity. So just bending over hurts, right? Just bending over to pick up a pencil during a test, and then your instructor almost trips on you. Okay. Right. So, sorry, I almost took you out today. Yeah, that's a true story. I kicked one of your classmates. I apologize. So. Pain can be exaggerated, okay? So it can be exaggerated by certain motions, but I will tell you this. If their pain is happening when they just are sitting down and they're coughing or sneezing, do you think the pathology is pretty serious? Yeah. You said no? Someone said no? Oh, no, it is, all right? Because they're not moving much. They're literally just maybe bearing down a little bit, right? And just moving that area very slightly, and they're having significant pain. So when you look at these things, when it says coughing and sneezing on there, that again, this could be a spectrum, right? So if they say, well, I have pain when I bend over, it's like, okay, so do I. But then they tell you, oh, I have pain when I cough or sneeze, and it's pretty severe, that can be a sign of more significant herniation, correct? The answer is yes. So buttocks and radicular pain, sure. And the distribution, again, is going to vary based on the nerve root that's affected. Okay, so if you're given a scenario on the test coming up very soon, right, and it tells you it's in a certain distribution, then you got to start thinking to yourself, okay, what do I think is going on here? All right, so this is the physical exam. You guys have seen this picture on the right before, correct? Yes, the answer is yes. So you have. So I give that to you guys a little bit in advance. We'll go through it in the lab again, but you guys at some point in the next however many days have to start nailing this down. What is L4? What is L5? What is S1, right? If you're given a scenario, what nerve root do I think is affected? Okay? So I will tell you that they can be standing, and they can have significant pain, so they're listed to one side, meaning they're standing tilted to one side, right? They report that they have limited forward flexion. So as we'll go through in the lab, when you're checking your range of motion, you have them bend forward, right? You have them bend back. You have them bend to the side. You have them bend to the other side. So the forward flexion can be decreased, okay? I made sure to highlight here something in yellow, okay? So do we think that's important? I would say yes, right? The cross straight leg raise and the contralateral straight leg raise, are those the same test? What's the rule? The answer is yes. Okay? So that's the same test. I don't want you guys to be confused by that. It's intuitive that if you do a straight leg raise, you guys practiced this in Clint skills many moons ago, right? Right? Seems like so long ago. Right? Somebody's saying no, so maybe they didn't practice. Right? But I'm just telling you, if you do a straight leg raise, it's literally what it sounds like. You have the patient laying supine, you have them lift their leg straight up. Is there a picture there? There is, right? And you're saying, what do you feel and where do you feel it? Don't tell them, do you feel pain? Because guess what they're going to tell you? I feel pain, okay? Again, we'll coach you a little bit tomorrow, or Wednesday, excuse me. Bless you. COVID. We'll coach you a little bit about kind of how to properly tell the test. I'm just kidding, not COVID. So that way are actually getting good information, okay? But the straight leg raise, they'll have pain on the affected side. And then you have them lift the other leg, whether they're seated or they're laying supine, and they have pain on the affected side, correct? So we all know that the military is full of fakers, right? Right, so there's a criteria that I will not teach you unless you ask me in lab, right? Where you can tell if someone's faking, right? And one of the criteria is when you do a straight leg raise, where's it supposed to hurt? On the affected side, but then all of a sudden they say, well, it hurts on that side, but it's not the affected side. If it's a cross leg or contralateral. Is that good? Does that sound like a faking criteria? It is. It's one of them, okay? I'll teach you a lot of things off mic, okay? All right, but just understand I highlighted this here in the slide. I cleaned it up, okay? So it's not as confusing anymore, correct? Seated, supine, the positive is the same, okay? Good? All right, and I can't stress enough that picture on the right-hand side there. You gotta know this. You gotta know it, because you're gonna get it both in written form and potentially in an OSCE, okay? All right, so are you gonna get radiographs if they have radicular symptoms? Yes, we just talked about that. This is not necessarily that acute mechanical pain that we talked about before. This is actual symptoms on exam, right? So you're going to get radiographs in this case. You're going to get AP lateral plus or minus obliques, okay? What are you going to see? You may see age-appropriate changes. If you get X-rays of my back, do you think you're going to see that LOSS, the loss? You're going to see it, right? But in this case, when are you going to get an MRI? Symptoms persisting for how many weeks? 4 weeks, okay? Unless they have significant neuro symptoms on exam. Okay, do you think I'm going to give you a scenario and it's going to be vague about the neuro symptoms? No, it's going to be significant. Is foot drop a significant finding on exam? Yeah, so would you get an MRI in that case? You better, okay? So you're going to get an MRI without contrast, okay? MRI without contrast if they have neurologic symptoms. And if they have a previous surgical history, let me back up, previous surgical history, okay, you're going to get an MRI with contrast. Do you think if they have surgery, they're going to have scar tissue formation? Do you think they're going to have changes? Yeah. If they had surgery, we don't just go in there and take a look. It's not like checking under your hood, right? So we want to highlight those changes, and we want to be able to tell what's new, what's different, okay? So again, surgical history, you're going to get an MRI with contrast. We good with that? Okay. It differentiates between a true herniation and what? Scar tissue. Okay? So, say you're going to do non-operative management of herniated discs, lumbar herniated discs. HNP, herniated nucleus pulsus. If you see HNP, that's what it stands for. HNP, herniated nucleus pulsus. Okay? So treatment, non-operative, pretty straightforward stuff, right? 1 to 2 days of minimal activity. You want to get them moving up, move them, right? Stiffness is the enemy, I promise you. Then you got a whole other set of issues to deal with. Right? You can give them a deadband profile. I don't know if that translates across all the services, but at least I know in the Navy and the Air Force, that basically means you can't do much. So what does that mean? No high impact activity, correct? No high impact activity. You don't want them doing prolonged standing, walking, right? Sitting, limit sitting, right? You want them up and moving. And you're going to do things like restricting their ability to put on a pack, necessarily jump out of a perfectly good helicopter, things like that, okay? Because most people will improve in how many weeks? 3 to 4 weeks, okay? If you just do the conservative care, most people will improve in 3 to 4 weeks. 3 to 4 weeks, okay? Now, if you're going to move to an ESI, right, epidural steroid injection, that is not something you do right off the bat, right? So if it's something where it's persistent, or you show progression, then you can potentially do an epidural stent injection, right? So that picture there, those pictures, excuse me, on the right-hand side, I worked at a spinal clinic where we had an interventional provider who did ESIs. He did, I don't know how many. I could just hear the cash machine ringing. Cha-ching, cha-ching, right? Because people have, this is a real issue, so there's no shortage of patients. But does it look like that's done under a controlled environment?
Yes.
Yeah, it's a controlled environment, right? So this is going to be a referral. You're not going to be doing this necessarily unless you go into interventional radiology. It's a growing field in the civilian practice, at least. I know there's guardsmen out there and women, right? Guards women. I don't know if that's a thing. So, but how many can you do in a 6-month period? 3. Okay, 3 in a 6-month period. Okay. Do you think if they're not getting any improvement whatsoever after the first one, we're going to do a second one?
No.
No. So just common sense, right? But for the purposes of what's going to be on the test afterwards, 3 in 6 months. Okay? Right? You don't just keep forcing your patient to get ESIs. If they're not improving, stop doing them. Okay? So who deals with this? Pain management, interventional radiology. All right? So non-operative treatment failure, right? So they've done everything, all that stuff. They've done ESIs. Do you think they're going to move on to see a spine surgeon versus a neurosurgeon? Yes. Okay? And the treatment of choice depends. There's just too much there. I will never test you on the differences between surgical approaches, surgical procedures, things of that nature. That's not the scope of this course, okay? But just understand, what's an ectomy? It's when you take something out, right? So if it's a discectomy, that stands to reason that they might go in there and take a piece of that out, right? To cause relief of the symptoms. And then if that's not enough, then sometimes they'll have to fuse the vertebrae together so there's no more motion there, correct? So if you have to fuse the vertebrae together, right, do you think the discs are doing anything anymore? No. So that's why it says discectomy plus or minus fusion. You good with that definition?
Right.
Okay. Enjoy the pictures. So that was what? Lumbar herniated disc. Okay. Now we're moving on to lumbar spinal stenosis. When we talk about stenosis, we talk about narrowing of a canal, and then where it is, right? Okay. And that canal is which one?
Lumbar.
Okay, it isn't the lumbar region, but it's the spinal canal, right? Yes, you're not wrong. You're just not quite right. Okay, so narrowing of one or more levels of the lumbar spinal canal. Okay, I know, I'm nitpicky, right? Words matter. So, because if you don't read those words, do you think if you see spondylolysis, spondylolisthesis, spondylosis, if you don't read and understand which word it's being used, you might get it wrong? Yes, right, and we'll talk about that a little bit, okay? Subsequent compression of the nerve roots, again. But do you think if it's lumbar spinal stenosis, the symptoms may be more significant? It's the spinal cord, guys, so it may be more significant, and we'll get into that a little bit more. 30% of those older than 60, okay? 30% older than 60. I don't know how valuable that number is, so it's not highlighted, okay? I'm not 60, thank you very much. But there is some lumbar spinal stenosis in my medical record, maybe, right? So sometimes things hurt worse than others. Is it positional? Absolutely 100%, okay? But what's the big thing to know here? What's the most common level? L4 and 5, right? L4, L5. L4 on 5 is another way to say that, correct? Okay. Oops. Let's not forget the picture. There's another picture there that shows you that compression there, right? You see on the right-hand side of that picture where it shows you the compression? Right, so that, again, the compression, depending on what level it's at, can also dictate the extent of the symptoms the patient's having. It is the lump. I'll take your next question. Oh, you are? Perfect. What do you got? Yes. It can be, so if I understand your question correctly, let me rephrase this question real quick. So he's saying, it says, multiple levels, right? So even though L4-5 is the most common. Can you have L2-3, L5-S1? Yes, right? So your exam will tell you that potentially, correct? Right? Would I get that tricky on, did I answer your question?
What I'm asking is
Yeah.
continuous, or can it be like L1 and 2 and then 4 and 5?
It can jump around. Yeah. So it doesn't have to be like if it's L1-2, then it's going to be L3-4, correct? It can be on multiple levels and be inconsistent, if you will, in this consistency. What's going to be consistent is that when you do your exam, you're going to know that chart, right? And you're going to know if they have loss of sensation in this area, right? It's potentially this nerve root. And now if I have loss of sensation in this area, it's another nerve root. Make sense? Okay. Would I get that tricky on an exam? In this case, the answer is no. Right? Because the reality of spine, guys, is that it's complicated. Okay? It is. This question is a really good question. Right? I just kind of skirted around the answer. But if it's actual spinal canal, it goes up and down, right? So do you think, again, like I told you about cervical, if you have cervical issues, do you think it could be affecting them down lower? Yes, it has to go to the cervical region to get to the lumbar region, correct? It's not like it has an extra pathway, right? So if you think about in those ways, you think, oh wow, that's why neurosurgery is so complicated. Because, you know, the clinical exam can be a little mixed. Make sense? Good question. Did I answer your question at some point? Okay, he was just saying that. All right, so lumbar spinal stenosis, so it's the canal, right? So this shopping cart sign, this is a pants favorite, right? Because it's got another buzzword. Who doesn't like, you know, shopping cart sign, right? So basically, if they're standing straight up and down, what happens? It's compression, right? And if they're leaning forward, less compression, right? So therefore, that's why it's a shopping cart sign, right? They're leaning forward like they're pushing a shopping cart, right? You guys have seen the white knucklers driving a car, right? All you see is their knuckles, you know, like how they start driving. And then they get out of the car, they go get a shopping cart, and they're leaning forward, right? Why is that? Well, they might have kyphosis, correct? But sometimes it's because their back hurts, and that's a position that causes relief. Make sense? Symptoms improve with forward flexion. That's the key term there, okay? Check, X. All right, there's a check mark there, and there's an X, right? Back pain standing straight up, okay? This, it's in white because the color that I was able to pull the best chart I could find is like some kind of weird green color. But this is a really good chart, kind of delineating the difference between neurogenic and vascular claudication, okay? In relation to what we're talking about now, right, it is important to understand, can you have vascular pathology that's also associated with neurogenic pain? Yes. So it's important to understand how things are different, okay? Am I going to test you on every line here? No. But just understand that, again, this is an FYI slide for you guys to help you, okay? What I want to make sure you guys understand is that you can delineate between vascular and neurogenic itself. Neurogenic literally means nerve pain, correct? It's coming from the nerve and nerve roots, etc. Vascular means it's not neurogenic, okay? So understand the kind of the vague difference between that and also how the patient may present. Okay, questions about that? Now, I just put this one straight into the slide presentation. That way you don't have another thing to click on. Oh my God, he gave us homework. All right, so adverse outcomes disease. So if it's progressive, right, as it stays there, do you think that they have a history of, oh yeah, I've always had back pain, but now it's gotten worse? And then your physical exam changes, right? You have more significant findings on physical exam. Probably you need to get an MRI. Okay, so that's the outcome of the disease, though, right? And it has an adverse effect on the quality of life. What are those three factors that denote when people are going to come see you? Work, play, sleep. When those three things are affected, they will come see you. And they will see you often. You're going to love lower back pain. It's going to be awesome. All right, physical exam, leg weakness is uncommon, okay? That's weakness, right? That's uncommon, okay? Can it be multifactorial? Yes, as we described earlier. But what you will see is a decreased reflexes, okay? Sensory changes, again, in a certain distribution, right? What distribution is the Achilles reflex? I heard S1, which is the right answer, right? So again, if they have S1, then they can have numbness, tingling, not numbness, true numbness, right? But decreased sensation in a certain distribution too, right? So if you go back and look at your chart, it tells you that. Make sense? So that's an example there. Proprioception may be impaired. What's proprioception? That's your ability, your body's ability, excuse me, to tell where it is in space, right? So, are you doing the moonwalk over there? Yeah, not that kind of space. Okay? So it's basically positional information that your body uses to tell where it is in space. Okay? They can have a mildly positive Romberg. That's that test on the right-hand side, right? They'll just be a little unsteady. Are you going to do a full neuro exam and also gaits? Yes, of course you are. Okay? Imaging, AP and lateral of the lumbar spine. So this is lumbar stenosis. So can they have intervertebral pathology as well? Yes. Okay, so you can see a narrowing, and there's that word spondylolisthesis. So that when you think of spondylolisthesis, I know you guys think about the Scotty dog, right? Collar, no collar? Okay, I got you guys in your activities. Okay? But just understand that that's slippage, right? There is slippage. So that's why you want to get a lateral, correct? So you can see that slippage. All right? And osteopenia may be present. Does that look like the spine of an old dude or an old person, I should say?
Yes.
It does. It's not my spine. I'm not that old. But it's, advanced age, right? There's so many things going on in these x-rays. But I'm just telling you, this is a very good example of, okay, if you were to get these x-rays and then you had access to the system and you looked at x-rays from like, say, 10 years prior, and you're like, wow, there's been significant changes, right? So then you're like, okay, that makes sense. So then you might get a number on it, correct? The answer is yes. Non-operative is the same, right? Water therapy is good. Why is water therapy good? Because it's low impact, correct? Okay, so water aerobics, water activities. Does TRICARE pay for it? No, right? Most places they do not. Okay, you wish, all right? But again, getting in the pool, just doing low impact activity, that tends to be the mainstay for this, okay? ESIs, epidural steroid injections, okay? How many are you going to do in a 6-month period?
3.
No more than 3, right? Okay. So if you're going to do surgery, you see those big screws there, those big plate-looking things. Those are called roll bars and cages, in case you care. But the big thing is that if it's causing compression, right? And by the way, there's spondylolisthesis, so there's slippage too. You want to stabilize all that, right? To minimize the symptoms. So do you think that doing a big construct like it's up there in the top right is going to do that? Absolutely. The thing to key in on this picture here is that when you look at this picture, okay, and you look at that bottom right-hand side, it says entire lamina removed. Okay? So if somebody has progressive osteoarthritis, right, those little fingery projections of spurs, right, bone spurs, and you have to remove the lamina, that's to remove that encroaching factor with that too, correct? So there might be a component of a laminectomy. Make sense? That's all that picture's showing you, not testable. But I just want you to understand that when it comes to spinal surgery, if you're going to make big changes, then you inherently remove the stability, correct? So then you have to stabilize it somehow. And that's why that big construct in the top right is performed. That's to stabilize the spine. Okay, so you don't have translation. Everybody understands translation, right? forward, back, side to side, and you don't have slippage. When I say slippage in this case, it's in the sagittal or lateral plane, right? Lateral projection, okay? That's all that picture is showing you, okay? Because I do get questions about that. But again, I'm not going to test you on surgical approaches, surgical techniques. Referral decisions, red flags. Anybody who has neurologic changes, gait disturbances, and bowel bladder dysfunction. Okay, there's the bowel bladder dysfunction. So if you have significant spinal stenosis, right, depending on where it is, can you have a syndrome? You can. Is it necessarily cauda equina? Not necessarily, right? I did mention another one, cornus medullaris syndrome, that is not testable. But just understand, bowel and bladder is bad, right? Bowel and bladder dysfunction, is bad. That's not good. The patient cannot self-regulate, right? That's an indication they could be heading down a certain path. So that's a red flag, okay? Any questions about that so far? All right. You want to keep pushing, or do you want to take a break? Keep pushing? All right, I'll start this, and then we'll take a break when we get closer, okay? Metastatic disease. So metastatic disease, we're talking Mets, right? We also use the word Mets. Patient had Mets, right? So this is cancer, right? This is some kind of malignant process. Malignant versus benign. Benign was the ganglia, correct? That's when we talk about benign. So metastatic disease, this is, I wouldn't say necessarily an emergency, but it's serious stuff, right? So when we talk about metastatic disease, the thing to understand about metastatic disease, or METs, right, is that they come from, it's in yellow and it's capitalized, from something. What are those somethings commonly for bone? Because I'm a bone guy, right? So we're talking about bone stuff. Malignant primary bone tumors are rare. Rare, okay? So that means if you find something on imaging, are you looking elsewhere? Yes, okay? That elsewhere is breast, lung, prostate, colon, thyroid, kidney. You need to know that list, okay? That's the same for my class. I'm saying you need to know that list, okay? Because PANCE will test you on it in some way, shape, or form as well. Maybe not even from Ortho, right? They'll just mention that there was a tumor found on the Ortho exam, okay? So, bone tumors are, again, these are not primary bone tumors, right? But bone tumors are more common than soft tissue tumors, okay? So that's another component to understand. So we understand the difference between those two aspects, right? Primary is not the most common, right? They're rare, but bone tumors are more common than soft tissue tumors when present. Probably a better way of saying it. Found when, okay, found by, we use the term incidental oma a lot in orthopedics and in medicine, period. Incidental oma, right? You're thinking this guy, he's just an old dude. Oh, look at me. All right, he's an old dude, he's got back pain, he's been having for years, let me get some x-rays. And then all of a sudden you see something, right? And you're like, ooh, I wasn't expecting to see that, right? Or all of a sudden something else, somewhere else, kind of shows its ugly head, right? When you're doing an imaging study, let's say they have wrist pain, and all of a sudden you're thinking, oh, it's probably a ligament sprain, strain. You use the word inappropriately all the time, right? That's a joke. But you're looking, and then all of a sudden you see this big pumpkin mass in the bone itself. You weren't thinking bone, right? You were thinking soft tissue. That's why you got an MRI. So that's an example of an incidental oma. Okay? You were looking, and all of a sudden you see something you weren't expecting to see. Okay, but pain is the primary symptom of cancer patients who are not aware that they had a primary tumor. Okay? So again, they had pain, so therefore you got imaging, and all of a sudden you find things. That's what that's saying. Okay? But pain was the reason maybe you got a study. Incidentally, when you guys order studies, is your indication going to be the word pain? It's literally just the word pain? No, right? I'll tell Major Passion, I'll tell them, I never write pain as the primary, right? Just the word pain, right? Use descriptor, be more specific. If there was a trauma, right, you write the letters MOI, semicolon, and you write what happened. right? Fall from a 3-story height. That's a mechanism of injury, right? Okay. Be specific. But pain that wakes them up at night, pain that prevents sleep, not that they're having discomfort and they wake up commonly and they can go back to sleep. This is pain that prevents sleep. Like they're not sleeping, guys. Okay? Right? That's the difference. Okay? Metastatic disease, pain that prevents sleep. Can they have all this stuff for any condition we just discussed? Yes. That's why, again, very commonly it's found as an incidental coma. Or incidental finding, I should say. Okay? Pain with weight-bearing activities, that can be acute lower back pain, that can be herniated discs, right? Standing, sitting, that can be anything. Right? Radicular or myelopathic signs and symptoms. So radicular, again, being that nerve distribution, and then myelopathy being the involvement of the spinal cord itself. Okay? On physical exam, you're gonna do a complete neurologic exam to include motor and sensory. Okay, pain with percussion, that can be variable. If it's more superficial, or if it's more extensive, meaning it's been there for a while, it's progressed, that can be more of a finding. Okay. Same thing with posterior tumors. The tumors are maybe palpable, sure. If it's big enough that it's been there for a minute, or it's highly aggressive, then yeah, sure, maybe you can palpate it. But the big thing, again, is that you're going to get the imaging and you're going to, what we call, characterize it, okay, differentiate it, get an idea of what's going on, okay? Kyphosis may develop with vertebral body collapse. Well, that could be due to anything, correct? But what they're getting with the vertebral collapse is that, and there's a picture coming up, is that the disease is advanced enough where it has occupied those structures and those landmarks in the vertebrae themselves and basically destroyed them, okay? Right? That lysis that we talked about, right? That destruction, okay? And therefore there's instability now because it ceases to exist, okay? So this is where you get the term pathologic fractures, okay? If you remember nothing else, understand that with metastatic disease, you can have pathologic fractures. So again, we've discussed this before. Pathologic fractures, right? So the bone itself has been invaded, okay? And then they have very minimal trauma, right? An insult or injury to a body part. And now they have a significant finding on radiographs. Pathologic fractures, do you think they're going to look different on imaging? Yes, that's why you're going to get them if there's some indicators that you're trying to rule out metastatic disease, okay? And there's the findings that I was talking about. So this is something you guys want to key in on. You look at that picture there in the center. You see how I put that big red circle there with a glow on it? All right, you're welcome. So if you can look there and you can see it, it looks like destruction of the vertebral body, correct? Compared to the vertebrae that's above it. Okay, so it looks like it's just no more. Okay? And that's why you can have a collapse of the vertebral height because the structure is not whole. Okay, that winking out sign, again, it has a cool little phrase, right? So Pants loves those. So that's that loss of the pedicle. So if you have a loss of the pedicle, you can have a collapse, correct? So if you look there on the right-hand side, squint really hard, you're like, that doesn't look like an owl, okay? But burn that image in your mind because that winking owl sign lets you know, it keys you in on the fact that this is the reason that this patient's having certain symptoms, correct? So that's what it is right there. Winking out sign, okay? Again, I put an arrow there, so you can be like, where is it, where is it? Does that look normal? There should be, there's a lot of white on the right side, not a lot of white on the left side of that vertebrae, correct? Is that normal?
No.
Incidentally, is there a rib attached to that?
Yes.
So what level are we at? Thoracic, right? Woo, putting it all together. I think it's blacked out. Okay? Are we good with that definition, the waking out? Was that part of your assignment,
Yes.
your activity?
Tell you later.
You'll tell me later? I'll find out at 11:15. Okay, got it. All right, so if you have a collapse, right, like we talked about before, so those structures cease to exist, okay? So is there many non-operative? Well, the non-operative is more focused on the cancer itself, correct? Because the primary bone tumors are rare. So you're going to do things like radiation therapy, chemotherapy, things of that nature, okay? So if you're on a PCM of this patient, you're going to be managing multiple referrals, okay? Hormone therapy, we talk about breast cancer, right? Okay. Was breast on the list?
Yes.
It was. All right. Radiation's on the screen. So was prostate on the list?
Yes.
Very common. Pants loves to ask you about pain in older gentlemen, again, older than me, don't judge me, okay, that have prostate concerns, and now they have night sweats, fevers, weight loss. What's the primary concern? Prostate cancer, right? Lower back pain. It's prostate cancer until otherwise proven. Okay, that might be a scenario that PANCE kind of throws at you. So what's the primary cause? It's the cancer in the prostate that is now metastasized to the vertebrae. We good with that? Okay, I think that's probably the best example I can give you. I saw that on my test review. I'm recertifying for the third time. I need to retire. All right, so operative management, again, you have a collapse, so therefore you got to do big things, right? You got to put big screws, big supporting structures to hold things in place so they don't slip, they don't translate, things like that. So that's that picture up top. Again, not testable. But when you're doing this surgery, do you think you're still doing the adjunctive radiation and all that stuff? Yes, you are, right? Okay. And all that surgical decision making will be driven again by the patient exam. So neurologic deficits, significant pain, right? Quality of life is significantly affected, so you may do that. Okay? So adverse outcomes of treatment. This is of treatment, not of disease, but you're actually treating it now. The neurologic deterioration persists in some patients. So despite your best efforts, you stabilize the spine, but you still continue to have progression. As you guys are learning in neurology, nerve pain is tricky stuff, right? So it's multifactorial. You can have very minimal changes and cause significant changes very far away, okay? So surgical wound complication. So do you think if somebody is immunocompromised from radiation therapy and or hormone therapy and a bunch of other different therapies, that if we make big incisions and go deep into their spine, that's pretty down in there, right? Yeah, we're tracking down. This is hours of surgery, not minutes, right? And then we try to close everything up as we go out, on the way out, that maybe those wounds won't heal like normal. Yes. So that picture there, and this is just an FY picture, but it's just showing you a tract, right? It's just not closing. So you may see that superficially and be like, huh. And then you put a cotton tip applicator in there and it goes, like, whoa, that thing is disappearing. All right, it tracks down deep because that wound just it does not want to heal, right? So then if there's a concern for infection, then sometimes we have to go in there and redo things, right? Wash them out. Make sense? Okay? So red flags in decision making. So I just went ahead and just set all patients. Okay? Yeah, there's some specific stuff that your book talks about. But I will tell you, if you're managing the C word, you're going to want to make sure you are referring these patients. Okay? And if you're unknown to the cancer source, refer to oncology. They'll scan them from head to toe. They'll do every scan on the man and try to find this thing. Okay? Try to find out how extensive it is. Okay, we gotta take a break. I'm losing people. Let's come back. 5 after, okay? The abnormal physical exam, abnormal x-rays. Okay, again, you see a young child, right? It says here what? Young, infantile, or juvenile. And you keep, yes sir.
Why this side is
Because the left-sided curve, and this is one of those things where I will give you an answer, right? And then I will stop, because then we get into a whole other set of issues. But left-sided curve, what side is your heart on? Okay. So if you put somebody in a recovery position after CPR, what side do you put them on? Okay. So it's like, well, we keep saying left, right? So that's an area that's in kind of like a protective position, correct? So therefore, if you have significant left-sided curvature, right, do you think it could be affecting your ability to have cardiorespiratory function? Okay, that's your answer. Now, it's in multiple planes, Major Douglas. You're not wrong. Okay. Pharrell? What's your last name again? Fennell. I was close. So that's one of those things where you understand, well, it's in multiple planes, so therefore there's more to it than just that is what I'm getting at. Make sense? But just understand that if you have that, you can see that curvature take off on you, and they can be more symptomatic faster. Okay? Are we good? Okay. You can ask me questions like that. It's not that I want to answer them, but it's just I don't know. It's too close to the test, guys. Okay. I want to throw you guys off. Make sense? I don't think anybody's stupid. That's not what I'm saying. It's just I don't want to go into that multi-dimensional. Your brain would have to rotate, right? So like, wait, but left to right, but then now I'm in the coronal plane, and now I'm rotating to the sagittal plane. So like now what's going on? So is your heart sit anterior or posterior?
Anterior.
Okay. Anterior? You sure? All right. Anyways. All right. Let's move on. Scoliosis. Cob angle. Do you think the cob angle is important? Yes. Okay. I mentioned that before, didn't I? Cob angle greater than 10 degrees is scoliosis. Bada boom. Okay? And bada bing. So when we talk about asymptomatic, so somebody comes in, this is what you're going to get. You're going to get a lot of children that are brought in by their parents, and the parents are going to say, it doesn't look right. I think something's wrong. And you're going to say, are they symptomatic? And they're going to say, no. Okay? Do you think conservative care is indicated? Yes, as long as the curvature is not significant, right? So if they're asymptomatic, the treatment is what? Observation. Okay? Skeleton immature, what does that mean? We mentioned the growth plates, right?
Underdog.
What's that?
I was saying that in the
Now what?
further skeleton.
Yes. I'm going to say yes. So skeleton immature. I'm sorry, I didn't understand what you said. Yeah. We'll get back to it. I'm trying to finish up with people. Skeleton immature. So bracing for 25 to 45 degrees curvature. Okay? So that means, is that kids or adults?
There you go.
That's kids, right? Young people. Okay? So if they're skeleton immature, right? So this is skeletally. That means their growth plates are closed, correct? That's what we're talking about. I think that's what he was trying to say, but I'm not sure. That is what he said. Okay. So NSAIDs, rice, activity modification, physical therapy, and swimming. So it's just conservative care, correct? Right? Unless, again, the curvature is significant. And then we shift over to operative, and that's where the curves come in. You see how I made that transition? Okay, so then you have to know what those, you take the left and the right and say, okay, now it got bad. Okay, so will we agree that 45 degrees kind of seems to be the trend there? Right? And then for adults, they can tolerate a significant amount more curvature than kids? Yes. Because kids, once they get to 45 degrees, do you think that curvature is going to stop? You got to stave it off and you got to pass, if you will. Right? And adults, it's like, wow, we're just going to let it curve till it curves. Okay? 50 to 60. Okay? Do you think there's going to be significant instrumentation involved? 100%. Okay? But we're still going to do non-operative treatment. Right? So even if that's just observation in kids. Good with that? Okay. All right, so there you go. That's pretty significant curvature. You see those numbers there? 69 degrees. Is that above the range that we just talked about? Yes. Okay. So that's a lot of shifting. These are long cases, six hours plus. Okay. Make sure you eat before you go to that case if you're rotating and they say they're going to do this case. Eat, hydrate, use the bathroom 5 times, right? Because you're going to be in there for a while. Okay. Infection. Neurologic injury, fusion failure, this is under what? Adverse outcomes of treatment. So obviously infection is post-operative complications, right? Now, other post-operative complications tend to be higher in adults or kids? The answer is adults. It's on the slide. Okay. So key in on that. Okay? All right. Red flags, neurologic symptoms. There's a common trend here. If they have neurologic symptoms, right, and they continue to deteriorate, you're going to refer them. And respiratory dysfunction. Okay? Those are the two main ones I want you to take away from that slide. We good with that? Look at the slide. Understand what it's telling you, but then remember neurologic deterioration and breathing. Okay? Respiratory dysfunction. Spondylolisthesis degenerative. Okay? Spondylolisthesis, we beat this horse many, many times. Right? Horse has no legs. So, but that's that slippage, right? That's that slippage of, in this case, if you look at that picture there, I see how I put the arrow and the number, the designation of L4, and then below it L5. Okay, so that's L4 on L5. That's how you decide that, right? So that's L4 on 5. So the slippage is occurring because L4 is anterior, or slipping, if you will, forward on top of L5. Okay? I've said L4, L5 many times, because where does it most commonly occur? L4, L5. Okay? And this is degenerative. So do you think if I give you a scenario and I tell you that it's somebody who's an adult and you're thinking it is spondylolisthesis, that it's going to be degenerative type?
Yes.
Yes. The answer is always yes, except when it's no. Okay? So women older than 40, mild to moderately overweight. I don't really know how valuable that is. Okay? But that's basically when they do meta-analysis, they say, okay, well, this is what commonly occurs. But what's the big thing to take away from this? We talked about this in the lab. Okay? What does it say there? Facet joints plus degenerative disc disease. Okay? The facet joints are affected here. Okay? So, radiculopathy is possible. That neurogenic claudication is possible as well, like we talked about before. Okay? Loss of curvature, sure. That could be due to a number of conditions, but it may be here. If that slippage is significant enough, do you think when you're running your fingers down their spine that you may feel a step off? Yes. So that's present there. But when you do a complete neurologic assessment, like you're always going to do, you're going to have diminished knee and ankle reflexes, not the biceps reflex, right? Because this is what again? What's the most common? Okay, so there you go. So you're looking at your scenarios. You're like, all right, I already narrowed it down because we only talked about these topics. You see how my brain works? I'm like, oh, we're not in these topics. We're in these two topics. Okay. Motor exam is usually normal. Okay. Diminished knee and ankle reflexes. Motor exam is normally normal. Usually normal. Okay, so degenerative, slippage on the lateral. Okay, so would you guys agree that even though that image on the left is flipped, right? Somebody took that image, clicked the button, and flipped it, right? Because the MRI is facing the other way, right? That you can still see that slippage of what level? L4 and L5. Good Lord. Okay, and you're going to see disc-based degeneration, maybe. Do you think if you have somebody flex and extend, that maybe that slippage is going to be more pronounced? Yes. So if you have more motion or you suspect instability, you're going to do those studies. Okay, flexion extension views. Okay? Pause for a second. Okay. So treatment. So when you talk about treatment, this is degenerative, right? This is like something that's occurred over time. So you're going to do non-operative management and conservative care. Then when it comes to operative, that's because you've done all the conservative care to include bracing. This is one thing when we talk about bracing, okay? So that bracing, again, we talked a little bit about this already. The orthotic, that's custom, right? That's something that's custom made for the patient, okay? They sometimes help, okay? They use a word occasionally, so that doesn't bode well for that modality, right? So what are your referral decisions? Well, definitely if you have neurogenic claudication, right? That's a spectrum, right? When you have claudication, that means it's significant. And if you have cardiac pointer symptoms, okay? So there's that slippage. Okay? Now, this is isthmic. Okay? So we've transitioned to a different topic now. Still spondylolisthesis, so you saw the slippage, but it's isthmic. So, what are the causes of this? So this is congenital and or stress fractures. Those are the causes. So congenital meaning they were born like that, okay? So this is that pars interarticularis defect. This is that spondylolysis, correct? So this is that Scotty dog, correct? It's that lysis, that Scotty dog. Okay, that now has a collar. Okay, and what kind of patients are these? So these are young patients, gymnastics, football players, people that are active. Then they start having symptoms in youth. I had one of our teammates tell me during the break that they were diagnosed with a condition, when they were young, and that they went on to have treatment for it. Right. So as they get older, do you think that their symptoms may continue? Yes, but usually if they're active patients in youth, they started having symptoms in youth. Make sense? So it's still slippage, right? But this is isthmic. We good with that? Different patient population, okay? That pars interarticularis is where the defect is, okay? Significant pain that radiates past the knees and worse with standing. Does it stop at the knees or does it keep going? Goes past the knees. Hamstring spasm, excuse me. So they may have tight hamstrings. Okay, so a lot of times the initial treatment for this is to put them in physical therapy to stretch the hamstrings. But the hallmark, as is written in your textbook, for this condition is that they have significant back pain that radiates past the knees, worse with standing, and has associated hamstring spasm. Okay? So obviously if it progresses, can you have all that stuff on the right? Yes. Paralysis is bad, right? We don't want that for our patients. So tight hamstrings limits forward bend, so they may have a decrease in their forward bend. Okay? Straight leg raise. Okay, when you go to raise their leg in a straight leg raise, passively, correct? Then you're like, man, I can't go much further. That may be due to their tight hamstrings, correct? That's what they're getting at there. Okay, so you're testing, you're like, oh, look at this. But neurologic defects are uncommon. Uncommon, because they're positional, correct? When you examine the patient, are you going to put them in a position that causes them maximum pain and then examine them? No. So their symptoms may be intermittent. That's what they're getting at there. Okay? Significant slip equals step off. That means if it's significant enough, you can feel it on exam. So that little blurb on the right-hand side there with the picture, that just kind of gives you an idea of what PANTS might ask you. It might be a patient between 5 to 7 years of age, okay, that don't manifest until adolescence or adulthood, depending on physical activity. So it may give you a history of somebody with intermittent pain in adolescence that now worsened as they got older, but no specific trauma. Because this is congenital, if we're talking about occurring in youth, correct? Okay, so it can worsen. All right, there it is. You guys love this thing, right? The Scotty dog. So is it normal or abnormal for him to have a collar? Abnormal. That's the collar. That's the lysis, right? So the Scotty dog collar is the defect. And decapitation is what? The slippage. Okay, not only did you give him a collar, but now you gave significant anterior translation of one vertebrae on top of the other. We go with that? Okay, there's some multiple images there. Of course, by now, you guys can just pick that out right from that image on the left, bottom left, right? You guys can see it right away. Of course. Right? So, if not, there's a big honking white arrow. Okay? And white arrows on the top right as well. Okay? But I do think at this point you understand that that might be something that you have to recall very soon. Okay? All right. So that's SPECT at the bottom, right? The single photon emission CT. Sure. If you can't decide where it's coming from, you can fire for fire for effect, if you will. Fire in all directions. Okay? And see what shows up, right? Because that's going to check the metabolic activity. I don't think that's something that I would pay too much attention to. But the X-ray findings for radiographs, yes. Okay. All right. There's the Scotty dog. Again, just for those of you guys, you asked very good questions. Right? If you haven't done your assignment yet, here's the answers. Okay, because that tells you right there what is the nose, the eye, the ear, the front leg, the neck. And the collar we already talked about. Which structure is it again? The pars interarticularis. Spondylolisthesis ismic. Okay? Those two go together. So skeletal immature, right? So you can try bracing. Right? Decrease loading activities. You tell a kid that you diagnosed with ismic spondylolisthesis that now they can't play football. Do you think they're going to stop playing football?
No.
Not unless they suck. Right? But if they're truly motivated, then they still want to go. Okay? So intermittent brace wear may be something that's in your treatment plan. Okay? But once you get to the point of, I'm sorry, at the bottom there it says skeleton mature. So why is that here? Because remember, we talked about that. I'm not going to point to the person, but we had talked about a person who said they had it in youth and it got worse in adulthood. Well, if they had ismic spondylolisthesis, right? Then, and when they get older, do you think they might have some degenerative changes? Yeah. So then you treat it the same as degenerative, correct? So that's conservative care. Okay? So, but once you get this is spondylolisthesis ismic, you diagnose them in youth, and they have a slippage greater than 50%. That's when you start having significant symptoms. So that's a referral. That's something we're going to do something about. Okay? Good? That looks like a big kid there. All right. Is that what you guys are laughing at? Of course not. Yeah, I think I was an adult. So that's your topics. What we talked about today is the herniated lumbar discs, herniated nucleus pulsus. Okay. We talked about lumbar spinal stenosis and how that's actually a narrowing of the canal. That's what we're talking about there, right? That can be affecting the cord, and if it's significant enough, it can affect the roots. So that's how that's different. Okay. And then we also talked about metastatic disease. Definitely know the red flags for metastatic disease, not just for my test and pants, but for your practice. Okay. Because you need to know when to refer. Okay. Scoliosis, multiple planes. So scoliosis is a curvature, and then if you also have kyphosis, that's a specific plane that we're talking about. Okay, know those numbers, how they're different between kyphosis and scoliosis. Okay, spondylolisthesis, degenerative versus ismic. Know the patient profiles or the types of patients that present with either. Okay, so you know how to classify them. When I get tricky and give you something that goes from ismic and then significant degenerative, the answer is no in this case. Okay, I did it on purpose. But I will just tell you that, if the markers are there for somebody who's, for example, a competitive, I don't know, give me something that kids do. Gymnast, competitive gymnast, right? And now they start to have the back pain, and then they have a pars interarticularis defect noted on the radiologist's report. What kind of spondylolisthesis are we talking about? Ismic, okay? Good to go. There we go. And what's the percent of slippage in ismic spondylolisthesis that you would definitely refer for? 50%. Are they going to be symptomatic?
Yes.
Yeah, you can't wait to get rid of that patient. All right. Refer them, excuse me. That's what I got for my little mini review today. I think we talked about Wednesday of next week for a formal review. The way I do my reviews, they will not. We're good? Okay. We good?
Oh.
Yeah. The way I do